Good afternoon, everyone. Sorry for the delay. Thank you for joining Debbie's Dream Foundation's webinar series. Today's webinar features Dr. Sahana Rajasekhara. I'm sorry if I mispronounced your name, who will give you a presentation on supportive care for cancer patients. I am Jennifer Higgins-Spires, Programs Manager for Debbie's Dream Foundation, and I will be moderating today's webinar. Thank you to our generous sponsors for making today's program possible. Title sponsors Amgen, Astellas, Daiichi Sankyo, and Merck. Platinum sponsor Taiho Oncology. Gold sponsor Arcus Biosciences. And silver sponsors Bristol Myers Squibb and Lilly Oncology. First, I will share information about stomach cancer and Debbie's Dream Foundation. Then we will hear a presentation on supportive care for cancer patients. And finally, a question and answer will follow the presentation. This year, nearly 30,000 Americans will be diagnosed with stomach cancer. Stomach cancer is a leading cause of cancer deaths worldwide after lung cancer, with a dismal 5-year survival rate between 20 and 30% depending on the country. Many patients are asymptomatic during the early stages of stomach cancer, leading to late diagnosis. Debbie's Dream Foundation is dedicated to raising awareness, advancing funding for stomach cancer research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at debbiesdream.org. Pictured here is Debbie Zellman, founder of Debbie's Dream Foundation. Debbie was diagnosed with stage 4 stomach cancer in April 2008. She had no risk factors and only vague symptoms. At the time, she was told that her chance of being alive in 5 years was only 4%. Debbie founded DDF in 2009 and dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education. Simultaneously, she endured harsh chemo regimens and targeted treatments and experienced many recurrences. Unfortunately, Debbie passed away on December 23, 2017 at the age of 50 after a 9.5-year battle with cancer. As an organization, DDF continues her important work and legacy. In a few short years, DDF has achieved many milestones. We have chapters across the United States, including Canada and Germany. Our PrEP program helps patients, their families, and caregivers match with survivors and caregiver mentors using disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer. We also have provided $1.45 million in research grants to date. Patient advocates come together each year at our annual Stomach Cancer Capitol Hill Advocacy Day to secure funding from the Department of Defense's peer-reviewed cancer research program, which allocates funds for stomach cancer research. Earlier this year, on February 5th through 7th, we traveled to Washington, D.C. with more than 150 advocates and held 250 meetings with lawmakers to inform them that we need more funding for this deadly disease. We are proud to say that this year was our largest turnout yet. We hope that you join us next year as we let Congress know that we need a cure. For the presentation, you can type your questions throughout the presentation into the chat section that appears in the webinar menu. We will address these questions at the conclusion of the presentation as time allows. Dr. Sahana Rajasekhara is the Interim Chair at the Department of Supportive Care Medicine at Moffitt Cancer Center. She is an Associate Professor in the Department of Oncologic Sciences at the University of South Florida College of Medicine. She is board certified in internal medicine, geriatric medicine, hospice, and palliative care medicine. She is a fellow of the American College of Physicians and the American Academy of Hospice and Palliative Medicine. Dr. Rajasekhara.
No worries.
Okay. With extensive experience in medical education, Dr. Rajasekhara is an instructor and an invited speaker at several local, regional, and national conferences. We will now begin the presentation on supportive care for cancer patients.
Hello, everyone. My name is Dr. Rajasekhara. I have been in the Department of Supportive Care for several years now, and the current interim chair and the medical director of the department at Moffitt Cancer Center. And I want to thank Debbie's Dream Foundation for inviting me to be a speaker. And should you all have any questions pertaining to the topic that we are discussing today, please feel free to share. I will address some of those questions at the end of the lecture today. So what got me into this particular subject? Supportive care, palliative care often, is mistaken to be what it is not. So my hope with today's presentation is to be able to inform you and equip you with the information that you need about what it is and how that can align with your treatment. So if any one of you needs assistance with symptom management, etc., you will be equipped with the knowledge to be able to avail to resources, ask for a supportive care physician, and thereby make your cancer care journey, as difficult as it is, a little bit better by having some of the symptoms controlled better. So we all know, we've talked about it up to this point, treating stomach cancer is often a team approach. There is more than one set treatment for stomach cancer. Often you need multiple disciplines, a multidisciplinary team of healthcare professionals with different backgrounds who come together to implement a treatment plan. And that is your cancer care continuum. This team, depending upon the stage, the kind of the kind of pathology you have, depending upon the diagnosis, etc., the team could include gastroenterologists, it could be radiologists, it could be medical oncologists. Those are physicians who are essentially doing systemic therapy, surgical oncologists. Those in particular deal with surgical treatment options for your cancer, pathologists, palliative care specialists, social workers, oncology nurses, and several other support staff. Though all of these people come together to chart out or map out a treatment plan for the cancer care journey or the cancer care continuum. As you noted, as I've noted there in bold, palliative care specialists can and are part of your treatment plan. So what I hope to actually be able to go over in the next several slides is to explain what supportive care is, what palliative care is, and how they can be an integral part of your treatment plan. So in terms of introduction of supportive care sometimes is interchangeably used as palliative care, sometimes interchangeably called as best supportive care. Regardless, some of the most common terminology is supportive care or palliative care. There is often a misconception of what palliative care is. Often people tend to think palliative care is care that is to be given at the very late stages of a patient's cancer care journey, a stomach cancer care journey. So what I want to be able to share is palliative care or supportive care, outside of what it actually is healthcare similar to a medical oncology care or a surgical oncology care. It's a healthcare given to patients to prevent, reduce, and relieve suffering and to help improve quality of life. So palliative care can include pain management. It could include addressing physical distress, emotional distress, supportive, spiritual support, and counseling where need be. Cancer and its treatments often lead to undesirable, unwanted side effects. While someone is going through their treatment, you also would like the undesirable side effects of the treatment to be better managed. Sometimes the side effects of the treatment overwhelms the patients far more than the treatment itself. To better manage the treatment side effects so one can continue their treatment is what we hope by adding us as part of your team, one can achieve the goal of not only continuing treatments outlined by your care team, including oncologists, but also at the same time improve the quality of life for both the patients and the family who are an integral part of anyone's cancer journey. So in the next couple of slides, I want to give you a pictorial representation of what palliative care truly is. So let's say we are thinking ourselves as a bridge. When you are young, you're healthy, the bridge is young, bridge is healthy, the load that it can carry can be immense. You're doing well, the load is, it bears quite a bit of traffic, quite a bit of load, and is able to withstand anything. But let's say you, the bridge, is facing a serious illness, any sort of serious illness, stomach cancer being one serious illness. The ongoing traffic, and let's assume the ongoing traffic is the visits to the hospital, the oncology, the treatments, the chemotherapy, the systemic therapy, the immunotherapy, radiation therapy, whatever it might be, the traffic or the number of treatments that one faces with time can falter or can make the bridge a little bit weak. So when facing serious illness, all of these treatments can lead to the bridge faltering and struggling to handle the load. When one struggles to handle the load, if we continue without any support, meaning without supporting the bridge, there is a potential for us to not be able to carry the load or go through the treatment because we are not able to withstand some of the toxicities, withstand some of the assault related to the treatments. So the bridge potentially could falter and struggle to handle the load. Best supportive care or palliative care is the support structure which can build reinforcement to your bridge, to you going through your treatments, thereby reinforcing the ability to continue some of your treatments. Building reinforcement to support you during your treatment is what palliative care is. So example, thereby all of those written in the red. Palliative care provides support to your bridge so you are able to withstand some of the treatments that are offered to you. So supportive care goes hand in hand with your other treatments. Supportive care essentially holds the symptoms together, holds you being able to tolerate the treatments better, thereby you could actually go through some of the treatments that have been outlined. Similar to what it takes to constructing a bridge, supportive care is also a team effort. What I mean by a team effort is supportive care or helping bolster your strength, helping boost your ability to continue treatment includes and involves a team effort. This may include radiation oncologists. This will include a supportive care physician, includes chaplaincy, includes a social worker team. So supportive care essentially, when you want to do a best supportive care, wherein the patient and the family is a unit, which is the center of the treatment plan, could be given by multiple other disciplines, including chaplain, social worker, pharmacists, nurse, bereavement counselors, physicians, etc. So in a nutshell, supportive care is a type of care focused on providing relief from symptoms and strengthen the person's ability to go through their illness. Any person of any age at any stage can benefit from palliative care, and the earlier the better. Instead of the thought that supportive care is downstream in a person's treatment plan, we hope palliative care with sufficient knowledge, equipping both the patients and the clinicians with the importance of early supportive care, we hope supportive care can be brought in upstream. So any person, any age, at any stage or type of cancer can benefit from palliative care, and earlier is better. So the model of palliative care that we hope that is going to be used by all is, instead of palliative care being at the downstream, we hope supportive care, palliative care can be at the time of diagnosis. Irrespective of the stage of diagnosis, there is always something that we can bring about, be it anxiety related to health, counseling around that, psychology, psychotherapy, psychiatry help, whatever it might be, assisting you all during your course of illness is what palliative care is. So it can be a tandem walk between oncologists and palliative care, wherein we share the treatment plan amongst each other as we outline the treatment plan to the patients. And as the patient advances from early stages to middle and later stages, there is more of palliative care or supportive care, meaning there is more of support that can be provided by a palliative care physician. So in terms of different aspects of palliative care, so palliative care, as I noted, can help with managing cancer-related symptoms, can help manage treatment-related symptoms. Treatments, whether it be chemotherapy, whether it be radiation, whether it's surgery, treatment in itself can cause some symptoms. A common example are treatment-related pain, treatment-related neuropathy. It could be surgical pain after having a surgical treatment. So there are many treatment-related side effects that can be managed better. Again, cancer-related symptoms. Cancer, depending upon where the stomach cancer is, the involvement of the lymph nodes, there could potentially be blockage. There could potentially be difficulty eating, loss of appetite, inability to consume chunks of meals, inability to digest and maintain weight. Some of these things can also happen with cancer, and those could be better managed by some of the specialists who are supportive care specialists. They also are good at addressing emotional well-being. Often there is a misconception that anxiety or depression or any mental health issues related to the diagnosis, there is a misconception that there is nothing to be done about it, that it's part of the diagnosis or part of what has happened to one because of their cancer diagnosis. What I would like to say is, emotions or anxiety related to what is happening is understandable. Having said that, sometimes when patients do have difficulty managing some of these symptoms, when the anxiety is significant enough that it is impacting their ability to go through treatments, there are medications and there are counseling services that can be offered that could potentially help a patient continue their cancer care journey. At the same time, along with doing all of the symptom management, be it physical symptoms or psychological symptoms, it is also important for us to be able to hear what your fears are, what your worries are, and what your goals are with regards to the treatment. The physicians should and hope to align their treatment plans to your values, to your beliefs, and to what you value the most. So ensuring treatment plan which is concordant to your values and wishes is equally important during your cancer care journey. So working alongside your oncologists, alongside your surgical oncologists in hand to map out a plan that provides the best quality, map out the plan that mitigates some of the side effects the best possible. At the same time, aligning with your wishes in terms of what your hopes are with the treatment is what we could facilitate along with your other team doctors. In terms of supportive care, some of what we excel in is the ability to do complex pain management, ability to control nausea, vomiting, treatment-related side effects such as fatigue, neuropathy, issues related to sleep, chemotherapy-related diarrhea. Some treatments cause diarrhea. So how best to manage those things? Is issues related to weight loss, issues related to difficulty eating, mood-related issues. These are all some of the symptoms that can be best managed by your supportive care medicine physician. So what I hope, so in terms of pain, since many studies have clearly noted that most patients with cancer at some point in their journey have pain, experience pain, and often note that pain was uncontrolled or pain was severe. So being very proactive in terms of managing pain better, if patients do experience pain, if you or your loved one experiences pain, it can be, the understanding is that it can be effectively treated, and there are medications which can effectively treat these symptoms. Regular assessment of cancer pain is a standard practice. It is a practice among oncologists, and it is a practice among all physicians who take care of you during your treatment. Should there be no questions regarding pain, it is important for you to be forthright in asking or noting that you're having uncontrolled pain, as treatment for pain does not impact your treatment for cancer. Those two don't go hand in hand. So they are independent of each other. At the same time, it's also important that the more the pain does not equate to growth in cancer at all times. So pain can be due to chemotherapy. Pain can be due to a surgical treatment plan that was given. So the amount of pain one has should not equate to the growth of cancer. And I would like to emphasize that you all be proactive in noting if you have symptoms of uncontrolled pain, noting that with your care team so they can continue discussion about available options. When it comes to treatment of pain, this is where we have several options, and sometimes this is one field in medicine wherein doing a little bit of everything goes a long way. When it comes to treating pain, we do have narcotics, commonly called as opioids, to help with pain. Having said that, they are not the only option to treat pain, because not all pain requires the use of a narcotic. We have non-narcotics available. We have medications which can be given to the surface, meaning these are topical medications. We have medications which can be we have injections which can be done. If a person has a set kind of cancer affecting a set area of the body, we could isolate that area and give interventional options, interventional pain management options. This is very similar to when a person has knee pain and the person goes through knee injections. There are several options wherein we could do different kinds of pain management. So I want to also assure the members who are listening that pain or telling about pain does not necessarily equate to being prescribed narcotics. There are other medications which can potentially help before one needs to go down the route of narcotics. Having said that, there is no fear with using narcotics for the pain, because pain addressed at the time is better than unaddressed pain, because unaddressed pain can lead to chronicity and other effects from uncontrolled pain. So narcotics, non-narcotics, radiation options, topical options, interventional injections as an option, are all various modalities that one has to be able to manage pain. That's why pain management is a specialty unto its own, and we often start by saying pain management is multimodal management, a little bit of everything. So up to this point, I essentially noted how important it is for us to manage pain better. What I want to take the time here is to let you also know that there is evidence behind integrating supportive care or palliative care early on. A study done in Boston, Mass General, which involved 150 patients of newly diagnosed lung cancer patients which had spread. They divided the 150 patients, randomized it into two arms. One arm was standard cancer care. The other arm included standard cancer care along with a palliative care physician involved at the outset of a person who was started treatment. The palliative care physician saw the patient automatically within 3 weeks, and they were followed for about at a monthly interval for about 3 to 6 months. What we found with this is those who got palliative care at the outset, wherein the palliation was integrated as part of their standard oncological care, those patients had improvements in not just mood, they had improvements in their quality of life, in their anxiety, the rate of anxiety, in their mood, and also some of these patients tended to live a little bit longer than those who did not receive care. So there is similar evidence in patients with GI cancer. Granted, the first study was about lung cancer. The authors decided to replicate the study to see if we can mimic the results from the previous study, and they decided to do another study wherein this study included GI cancers, patients including stomach cancer, pancreatic cancer, or various other GI malignant, gastrointestinal malignancies. Similar to that, they found results of improved mood, improved quality of life, better tolerance to the treatment, longer tolerance to treatment, and they also found that these patients did a little bit better. So having said that, I hope in the lecture I've given that I've given you enough, equipped you with enough ammunition to be able to avail to this particular field of healthcare, and avoid some of the misconceptions that palliative care or supportive care is only available at the very later stages of a person's illness. So I will stop here and see if you all have any questions in the chat or otherwise.
Rajasekhara, thank you so much for sharing with us today. I'm looking to see if there have been any questions so far. So far, we have not had any, but so feel free to take some time to write out any of your questions. Your presentation was so informative. I think you answered everyone's questions.
Thank you very much.
Yeah, I think if I haven't seen any come through, I can maybe ask people if they have some as time goes on. I can relay them to you, but I think for now, I think your presentation was amazing, and thank you.
Thank you.
So we will end this portion of the webinar. I would like to let you know some upcoming events that are coming. Please visit the DDF website and register as you can. So this concludes today's presentation. We'd like to again thank our speaker for taking time out of her busy schedule to present for us today. And thank you to our generous sponsors for making today's program possible. Title sponsors Amgen, Astellas, Daiichi Sankyo, and Merck. Platinum sponsor Taiho Oncology. Gold sponsor Arcus Biosciences. And silver sponsors Bristol Myers Squibb and Lilly Oncology. To view any of the recorded webinars, please visit our lecture library on the DDF website at www.wstream.org. Again, this concludes today's presentation. Thank you for turning in.
Thank you.